Welcome back to Diabetic Foot Files, the podcast where we peel back the layers of diabetic foot disease, not just the wound itself, but the life that surrounds it. I'm Dr. G. So today we're going to be discussing something that almost every patient wonders, but very few patients understand, or even physicians. I had to learn just while doing field work, right? Field work is like you're in it while you go with patients, and that's disability. Because when patients hear the word disability, they often imagine it as the permanent layer, and they worry that accepting the disability means that they could fail or that they would never work again. Others assume that because they have a diabetic foot ulcer, disability benefits automatically follow. But the truth is, it's actually quite complicated. It really is quite complicated because I had to deal with it with my patients and going through the process and how long it is and the different paperwork. It's a lot of paperwork, and understanding it can help relieve a lot of fears. So imagine this, a 57-year-old man walks into the clinic with a plantar ulcer beneath the first med head. It's been there for months. Before you even begin examining, he asks the question, am I going to lose my job? Not, will this heal? Not, will I need surgery? The biggest concern is, will I lose my job? And because while us healthcare providers, we see a wound, patients see not just a liability, but they see their mortgages, they see their rent, they see their groceries, they see tuition, they see retirement savings, they see the possibility that this one ulcer can unravel all the years of financial stability that they had. And this is why disability is simply not just a medical topic, it's an economic topic, it's a psychological topic, as well as a family topic. So what does disability actually mean? And just be honest, this is going to have a series because it's quite a lot of different components of disability. So one of the biggest misconceptions is that disability is a diagnosis. It isn't. Disability is a description of how much a medical condition limits your ability to perform work or daily activities. So, two patients can have nearly identical ulcers, but two very different levels of disability. So, imagine patient A. They work as an accountant. They spend most of the day seated. They have an ulcer at the bottom of their foot. They are able to wear the offloading device while working at the desk because they have a non weight bearing, demanding job. Patient B works in construction. His job requires him to climb ladders, carry heavy equipment, walking across uneven terrain, standing for 10 hours a day. This is a very weight demanding job. So both have the same ulcers, but two very different demands from their work. From one, their work can accommodate because they have a seating job. They can stay off the foot. But the other one with the construction, right? For the other one, they have if they continue working, they're gonna worsen the ulcer, delay the healing because it's weight bearing demanding, increase the risk of infection and potentially limb loss. And I've told the story before with one patient I had, it was really bad ulcer, had to go to ER immediately. They were asking me if they can go back to work, like, just for the rest of the day, okay, because they didn't wanna lose their job, and this is, like, there's some gas in there, and they wanted to go back to work and said, "I wanna work a few more hours so that I don't lose my job and I can get some money and my boss will understand what's going on," and that's so disheartening to hear that people care more about their job than their health now these days because they're afraid of the consequences, right? Because of what's going on. That's so sad that they felt so afraid that they felt like their boss would not understand. And obviously, they probably know from experience that the person wouldn't understand. And just from other patients' experiences, I've heard bad stories like people getting not fired, but just taken away off their job. And this is why disability decisions focus on functional limitations. And on a side note, in the end, she did go to the ER immediately. I had to convince her this is very serious. I said, I will call your boss if you want me to. I will, because this is not something to play around with, right? So, does every diabetic foot ulcer qualify? for disability. So this is probably the most common misconception. Patients believe I have a diabetic foot ulcer, therefore I'm disabled. Not necessarily. Likewise, some patients think I've been told I'm not disabled because I can still walk. That isn't necessarily true either. So the diagnosis alone does not determine the disability. As healthcare providers, insurers, employers, and disability programs generally look at questions such as, can this person safely perform the essential duties of their job? Does standing or walking worsen their condition? Are you required to remain non-weight bearing? Is there a serious infection? Have you had surgery? Do you require frequent medical appointments or dressing changes? Are you at high risk of further injury if you continue working? So these are some of the questions that paint a more clearer picture than the diagnosis alone. So why are some ulcers more disabling than others? So not all diabetic foot ulcers are the same. So we have to consider other factors that can increase disability, such as location, right? So a small ulcer beneath the heel is far more limiting than, let's say, an ulcer that's on the top of the foot. Either way, I would ask my patients not to go to work. Okay, if they have a sitting job, that's more understandable. But because if it's on the heel, right, the heel carries a lot of weight. And if they have a weight bearing demanding job, I need you off that heel. Okay. Next is depth. We have to think about the depth of the ulcer. An ulcer involving only the skin, let's say it's a partial thickness ulcer, will heal relatively quickly. But if it's an ulcer that extending the tendon, bone, joint, that that will require prolonged treatment, maybe surgical intervention, and stricter activity restrictions. If there is an infection, that is not something to play around with. An infected ulcer usually requires intravenous antibiotics, surgery, hospitalization, repeated debridements. That would make work quite difficult. And then if there's circulatory issues, if circulation is poor, healing is slow, that increases your risk of complications and even possible limb loss. And then offloading requirements. Oh my gosh. I am having a little bit of stuffy nose. So, offloading requirements, a total contact cast, a knee scooter, a wheelchair, a strict non weight bearing instructions can dramatically affect the person's ability to work. So, there is temporary disability and then there's permanent disability. So the distinction is quite important. So many patients only need temporary restrictions while the ulcer is trying to heal. The goal is to protect the foot long enough to heal, right, for healing to occur. And once the wound is healed and strength and mobility have returned, many people can resume work. Permanent disability is quite different. It may be considered long term complications that will prevent somebody from returning to their previous occupation or in some cases from working at all. Examples of this is like a major amputation with significant functional limitations, recurrent ulceration despite appropriate care, severe neuropathy with balance impairment, advanced vascular disease, or multiple diabetes related complications that are affecting the vision, the kidneys, the heart, things like that. Even then, the outcome depends on the individual's overall function, occupation, and rules that are relevant to the disability program. Now, we have to deal with the emotional weight of the question when patients ask, do I qualify for disability? Because I remember my first patient out of like residency when I had to deal with that. And it was quite interesting. I had to ask people like what to do. Yeah, I had to ask other doctors like what papers do I fill out, things like that. Okay, and they're actually asking something much more deeper. You have to remember they asking if they will be able to provide for their family. Will they lose their independence? Will people see me differently? Will my life ever get back to normal? And as clinicians, it's worth recognizing the fear behind that question because addressing that fear with empathy and clear information can be just as important as treating the wound. So, as podiatrists, we're simply not just measuring the wound, we're documenting how the wound affects the patient's life. So, our notes may describe the wound size, the location, the signs of infection, the weight bearing status, the prescribed offloading, the mobility limitations, expected healing time, whether there's work restrictions are medically necessary or not. But accurate documentation helps a good amount and help guide treatments, supports communication with the employers and the insurers, and provide objective record for the patient's functional limitation. Another question that patients will ask is, how long will I be out of work? So every healthcare provider has experienced this moment. We've examined the wound, we reviewed the x-rays, we've measured the ulcer, and we've discussed dressing changes, and we talked about glucose control. Then the patient looks directly at you and asks, so when can I return back to work? And the honest answer is often the hardest one to give. I don't know yet. Yeah, and that's the truth, right? Because we don't know how the wound's gonna act. If we have a better idea, like, if it's osteomyelitis, I'll be like, "Yeah, it's gonna be a few months," okay? But patients don't like uncertainty. Neither do physicians, let's be honest. Nobody likes uncertainty. But wound healing isn't like a strep throat where you do antibiotics or like fixing a broken bone where you put a cast and say 6 to 8 weeks, right? Every diabetic ulcer follows its own course. I always tell people that everybody's ulcer or wound has its own personality and it depends on the actual person who has the wound and their environment. It plays a huge role. So another thing people have to understand is that healing doesn't follow a calendar, okay? One of the biggest misconceptions is that every wound heals with a predictable number of weeks, okay? So patients often ask, will it take 2 weeks, maybe a month? Will I be back to work by Christmas? Can I go on vacation next month? And the reality is that healing depends on the biology, not on the birthdays, not on the holidays. Your body does not know you have a wedding in 3 weeks. It does not know that your mortgage is due. It does not know that your employer needs you back. It heals at the pace of your circulation, your immune system, your metabolism, your nutrition, and your tissue repair, what your tissue repair will allow. So, why does one ulcer heal in 4 weeks and another one could take possibly a year? So, imagine two patients. Both have ulcers measuring 2 centimeters. Both have diabetes. At first glance, they seem identical, but one heals within 6 weeks. The other one is still receiving wound care a whole year later. Why? Because the wound size is not the only piece of the puzzle. Healing is influenced by a dozen of interconnected factors, and we'll explore the important ones. Factor number one, infection. Infection changes everything. A clean wound can progress steadily towards healing. An infected wound can suddenly deteriorate. Bacteria increase inflammation, destroy healthy tissue, can produce enzymes that interfere with healing. So we already know biofilms is a huge thing. That slimy protective layer that shields them from antibiotics and the immune system. These biofilms can make wounds appear stalled despite the appropriate treatment. A superficial infection may be treated with oral antibiotics. A deeper infection may require hospitalization, intravenous antibiotics, surgical drainage, repeated debridement, or even partial amputation. Every additional complication can extend the recovery. Next factor is blood flow. So you can heal tissue that isn't receiving enough oxygen. And peripheral arterial disease is one of the most important predictors of delayed wound healing. Imagine, you're trying to build a house and now imagine the trucks carrying the bricks, the lumber, and the concrete. They never arrive, and the workers are ready, and the blueprint is complete, but the supplies never show up. And that's poor circulation. That's how poor circulation when it comes to wound healing. Without the oxygen and the nutrients, the body simply cannot rebuild the tissue effectively. And some patients require vascular procedures before even healing can begin. And we talked about delayed referrals, okay? And next is your blood sugar control. So we already know high blood sugar affects nearly every stage of wound repair. It can impair the white blood cell function. It can increase the risk of infection. It can damage the small blood vessels. It can reduce collagen production. It can slow the formation of new tissue. It can delay remodeling of the wound. This doesn't mean that every patient with a high hemoglobin A1C will heal poorly, but it does mean that glucose management is one of the most powerful tools a patient can have within their control, right, to help support their healing. Next is pressure. One of the most frustrating realities of plantar ulcers is that every step can undo some healing that occurred the day before. So think about trying to close a zipper while somebody keeps pulling it open. And that's what repetitive pressure does to a wound. And a patient often says, I only walk to the mailbox. This is when I always hear I walk to the bathroom. Okay. I just stood for the kitchen for a few. No, and that's not true because when I get my dressing, it's very dirty. It looks like at the bottom of a shoe. And even though these seem like small activities, this repeated stress on the healing tissue, especially when you have neuropathy, that prevents pain, that gives you a warning signal that something is wrong or you're doing too much, can delay healing. Next is offloading. So this is where adherence becomes quite critical. We just kind of piggyback off of the last factor. So patients may receive possibly a total contact cast, a removable walking boot, a custom footwear, a knee scooter, crutches, or even a wheelchair. But with that, a device only works if it's used consistently. So many clinicians have heard the phrase, I only took the boot off for a little while. Unfortunately, a little while repeated every day compounds and becomes enough for delayed healing. And offloading isn't a punishment, it's a prescription. It's actually part of your treatment. Next is nutrition. So that's why nutrition plays a huge role. Okay. We know healing is metabolically expensive. Your body needs protein to repair new tissue, calories to fuel repair, vitamins and minerals to support cellular function, and adequate hydration. And our patients that are malnourished intentionally restricting food intake or experiencing chronic illness may struggle to heal despite excellent wound care. So, we have to always remember nutrition is often an overlooked part of the treatment. We don't really ask our patient, what are you eating? What type of foods are you eating? We might ask your blood sugar, but what are you eating on a daily basis? What was your last 3 meals? Things like that. Smoking. See, I'm always very serious when it comes to smoking because you're not supposed to do that. You just know you're not, okay? There's enough evidence and papers, and they even have a warning sign on the cigarette pack. But smoking reduces blood flow, decreases oxygen delivery, impairs the body's ability to repair tissue. And I understand it's a comfort. It becomes a part of a habit, a daily habit, so definitely need to have somebody to help you with that, but it really does impair, okay? And if it has to do between losing your limb and stop losing the cigarettes, I think most patients will pick the limb, right? But even if a patient has normal blood sugar and excellent wound care and they're smoking significantly, that will delay the healing significantly. And this is one of the most modifiable risk factors that we can discuss with patients. So healing doesn't mean that you're ready for work. Okay. So when the wound is closed, everybody's like, yeah, I can go back to work. Yay, yay, yay. Right. But the tissue beneath the skin, right, underneath that surface is still remodeling. Remember we talked about the remodeling phase and how long it takes, okay? Because it has to move from one type of collagen to the stronger type of collagen, right? And think of it as fresh concrete. It looks solid after a day or two, but it continues to cure and gain strength over time. Similarly to a newly healed skin is more vulnerable than the mature skin. And remember, the once it actually does heal, even when it's at the end of the remodeling phase, maybe it takes a year or even longer than a year, it still will never be the same integrity as it was before the ulcer. Like maximum is probably going to be 80%, okay, or 86%. I can't remember exactly the percentage, but it will never be that 100% skin integrity as a normal skin that never had an ulcer along that area. So that's why, your healthcare team may recommend a gradual return to activity even after the ulcer appears to be healing. So, returning to work is all about function. So, the decision to return to work isn't basically sold on whether the wound is closed. It's based on questions like, can you perform the job safely? Can you protect the healing area? Can you wear the necessary footwear and offloading device? Will returning to work increase the risk of recurrence? Can your employer provide temporary modifications? That's something we have to fill out the paperwork for all of that. And for some people, returning to work may be appropriate while the wound is healing, and for others, waiting a little bit longer may prevent months of additional treatment. Okay, so every patient is different, but for me, it really depends on the weight bearing demands, how lenient the employer is, if they're understandable. I mean, there are quite a good amount of laws that protect the employee. And another thing, we have to set realistic expectations. So one of the most valuable things clinicians can do is avoid giving patients false certainty, like, oh, you'll definitely be healed in 4 weeks, right? They say under promise and over deliver, right? So you say things like, we'll monitor your progress closely. Every week, we'll reassess the wound, your mobility, your ability to return safely. Everybody on this team is working arduously to get you healed and to return back to a good quality care of your life because our goal is to get you back as soon as possible, as soon as it's medically appropriate, but not before your foot is ready, okay? And, hope without false promises. So patients should know that many diabetic ulcers do heal and many people do return to work, but time varies. Even some patients, I've had patients even get different jobs. You know, some recover in weeks, some recover in months. Sometimes it takes a year. They do. I know my patients, especially a lot of patients, a lot of the men too, they want to return to work. Okay, men and women, it depends on their job, but they wanna return to work, but my most disheartening one was the one with the really bad infection, and she wanting to go back to work for a few hours and just get admitted later that night. I'm like, "No, this is gas. This is like it's shredding up your leg. No, no, no." Okay? So, the goal isn't simply just to heal the ulcer quickly, the goal is to heal it well, because rushing back too soon sometimes leads to other setbacks, right? So you never rush anything. That's one thing I've learned, never rush a wound, okay? I tried to suture a wound, it burst back open. It was, like, almost there, and yeah, so one thing I've learned, that's one thing I've learned, you can never rush a wound. It knows when it's done and it's healed, okay? So, if you're listening today and wondering, how long will I be out of work? Remember, your recovery isn't determined by the calendar, it's determined how your body heals and how well the wound is protected and how effectively the underlying conditions are managed and how closely you and your healthcare team are working together, because healing is a journey. And you as a healthcare professional, we go through this journey with our patients. Every follow-up is something interesting or different, but you get to know exactly what's going on in their daily life, if they didn't get their benefits as yet or fill out this other paper or they said no or it's all these different things. And sometimes it's very disappointing to hear certain insurances deny certain things and make it even twice as harder for the patient, and I'm like, "What is going on?" You know? But, we're gonna it's disability is a big deal, okay? And I'm gonna have to do another episode on the other parts of it because, a diabetic foot ulcer does not automatically mean somebody qualifies for disability. Likewise, a person does not have to be bedridden to have legitimate work limitations. So the key question is not what diagnosis do you have? The key question is how has this condition changed what you can do safely, okay? And that's the heart of disability medicine and why it's an individualized assessment is so important. So this is this episode of Diabetic Foot Files. I hope everybody enjoyed it. This is going to be multiple parts because disability is quite complex. And so I'm Dr. G. This is Diabetic Foot Files, and take care of your feet because they take care of you.